Good afternoon, everyone, and welcome to the February meeting of the Perth and Kinross Integration Joint Board. Firstly, can I ask if there are any apologies today? If you can indicate either by just speaking up on this occasion or by putting a comment in the chat. No apologies.
Sorry, Chair, just to advise, I believe we only have apologies from Stuart Hope today.
Thank you, Scott. Thank you. And I would now ask Scott, please, to take a roll call of voting members, non-voting members and stakeholder members. Thank you, Scott.
Thank you, Chair. Good afternoon, members. If you could, when I call out your name, if you could just confirm that you are present in the meeting. Councillor Duff.
Present.
Councillor McDade.
Present.
Councillor Purvis.
Present.
Bob Benson.
Present. Stakeholder members. Thank you.
I think that was a present from Bob.
Slightly strange.
I've seen you pop up there, Bob, so I know that you're there. Ronnie Erskine.
Yes, I'm here.
Pat Kilpatrick. I think Pat was maybe having issues joining. I'm not sure if she's joined the meeting yet.
Present.
Maybe I'll come back to Pat. I'll move on at the moment. Gordon Patterson.
Yes, I'm here, thank you.
Jackie Pepper.
Present, thanks.
Jane Smith.
Present.
Dr. Lee Robertson. Don't think we have Dr. Robertson. Sarah Dickey.
Sarah Dickey isn't here, but I'm Sandra Gourley. I'm Deputy Associate Nurse Director, and I'll be at the meeting today.
Thanks, Sandra. And Bernie Campbell.
Yes, present.
Thanks. Alan Drummond. Don't know if we have Alan today. Sandy Watts.
Present.
And Sandra Auld.
Present.
And Lynn Blair.
Present.
Thank you. I'll just come back. I don't know if Pat Kilpatrick's managed to join the meeting yet.
No. Okay, hopefully Pat can join us shortly. Thank you, Scott. Okay, moving on to item 2 on the agenda, declarations of interest. Can I ask if there are any declarations of interest in respect of any items on today's agenda? Silence. Okay, thank you. Moving swiftly on. As members are aware, there is a shorter agenda today than normal. This is a pragmatic approach that we've taken in order to allow all members appropriate opportunity to scrutinise and seek assurance on important aspects of the work of the Perth and Kinross Health and Social Care Partnership, while endeavouring to still allow the Executive Officer team to retain its vital focus, especially on the pandemic response alongside its other duties. There is nevertheless, as always, a lot of ground to cover over the next 2 hours, and so I seek everyone's cooperation, please, so that we can get through the agenda efficiently. To ensure all members who wish to ask a question or make a comment are able to do so, can I please ask that questions are asked succinctly and indeed that answers given are as focused as possible. Once everyone has had the opportunity to ask a question, if time allows, I shall try to allow time for any further questions before taking comments, which again should be as focused and brief as possible. And And as a reminder, please do use the chat function if you wish to ask a question or make a comment on any paper. Simply type the letter Q for question or C for comment, and I shall then come to you in turn. Finally, in housekeeping matters, with members' approval, I propose that we amend the running order today to take item 8, the Chief Officer's report, ahead of the finance report and other papers at item 7. Is that agreed? I should take silence as agreement.
Agreed.
Thank you. Thank you. Okay. Now, before we continue with the formal agenda today, I just wanted to take a moment to express the sincere thanks of the Integration Joint Board to all of the social care and health staff in Perth and Kinross who continue daily to show extraordinary commitment in their various roles as they deliver all of the services on which so many citizens rely. It is now just over a year since this global pandemic reached our part of the world, and our staff have not just stepped up to the plate, they have remained on the front line throughout this most difficult 12 months, despite the risks, work pressures and emotional stresses that they have faced and indeed continue to face. And then there is, of course, our executive team led by Gordon Patterson. The leadership and unswerving commitment they have all shown throughout this period, very often including evenings and weekends, is truly remarkable, and again I thank them all. As a board, I am sure we all recognise that our people are our most valuable resource, and there is no greater priority for us all than their well-being throughout these most challenging of times. Finally, amid this COVID pandemic, and I've just lost my note, hang on, there it is. Finally, amid this COVID pandemic response, I did just want to very briefly mention the other major news within the last 24 hours, which is likely to present significant change in the social care landscape of Scotland. As you'll be aware, the Scottish Parliament has supported the recommendations of the independent review of adult social care led by Derek Feely. These include the scrapping of all non-residential social care charging, the establishment of a human rights approach to social care, further recognition of the role of unpaid carers, and importantly for IJBs, the creation of a national care service for Scotland that provides a consistent service for users and truly values its staff. We already do, of course, with local strategic oversight and input by reconfigured integration joint boards. The Vice Chair and I met within the last couple of hours with the Cabinet Secretary on a national call this morning, and suffice to say, and I'm sure Bob will agree, there are both huge opportunities and significant challenges for this. And all IJBs, for this and all IJBs in the coming months and no doubt years ahead. I have asked Bob Benson, Vice Chair, to briefly comment later this afternoon during discussion following on from the Chief Officer's report to say just a little bit more about what the CABSEC has invited us all to do as IJBs in the short term. That is all for the future, however, and so without further ado, can I now move to the here and now and item 3, the minutes of the last IJB meeting on the 9th of December. Is everyone content with the accuracy of these minutes, and can we agree them? Not hearing any dissent at the moment. So I shall take that silence as agreement. Thank you. Okay, moving on to item 4, action points update, and I'll ask Gordon to say some words at this point in time.
Thank you, Chair, and good afternoon to everybody. So we have 2 action points that are retained on the update, and these relate to, in the first instance, an update on progress in delivering on the strategic commissioning plan. This is one item that has been deferred as a consequence of the focus that we're currently giving to the COVID pandemic. However, members will recall that when we have previously sought to report on our remobilisation and recovery and response activity, we've read across to the commissioning plan and sought to provide some assurance that we continue to pursue the same activities, or we continue to seek to deliver on the same strategic objectives, albeit we are taking a different route because of the actions that have been necessary in response to the global pandemic. So that matter will be something that we will hope to revisit in April, at which point we will have the terms of reference for the strategy groups, and we'll also have developed our intended approach around reinstating the strategic planning group and looking at how we can further revitalise and support the third sector forum. So that work is certainly ongoing. The other item that's included in the action point update is the need for us to continue to report on the progress in relation to the Tayside mental health and wellbeing strategy, and a particular item that we will look to return to report on, which was the IGB had highlighted that whilst they were content to approve the strategy in the form that they saw it, there was still a need for the financial framework to be shared and considered by the IGB, particularly given the strategic planning and commissioning responsibilities. So the intention is that we will bring back a report, hopefully in April, subject to some of the other demands, as I say, that we're continuing to experience. Thank you, Chair. You're on mute, Eric.
You're on mute at the moment.
Happens to us all. Apologies. So are there any questions on Gordon's report? Okay, item 5 is, are there any matters arising from that report? No, don't appear to be any comments there either. Thank you. So moving swiftly on to item 6 on the agenda, which is the. Oh, hang on a second. Thanks, Bob. I've got your comment there. Okay, so moving on to item 6 on the agenda is the membership update. And Scott, can I ask you to speak to this report, please?
Thanks, Chair. Just to briefly advise that members will have noted that Peter Drury is no longer a NHS voting member of the IGB. NHS Tayside are looking to fill this vacancy and advise us of a replacement as soon as possible. Norman Pratt continues to act as a proxy member for the IGB, but is not at the meeting today. The other update is just to note that the ongoing election process for the service user representatives continues as per recent information that was circulated to all members for information, and it's expected that the outcome of this will be reported back to the IGB in due course. Thanks.
Thank you, Scott, and we have a question on that from Councillor McDade, and if I can ask if anybody else has a question, if they can put that queue in the chat at this point in time. Councillor McDade.
Thank you, Chair. Yes, I'm just slightly concerned that we're approaching yet another change in membership when this has been picked up by various inspections and audits, and I'm wondering, perhaps, Chair, if you could express to NHS Tayside it would be helpful if we could have a member of the NHS Tayside board that has already been a member of the Perth Kinross Integration Joint Board. We have had quite a few of them on the board before, so it would be beneficial to the board, I think, if we had someone who will not have to spend as much time getting up to speed on the work of the board.
Thank you for that, Councillor McDade. And before I respond, I see Mr Patterson has a comment to make.
Yes, thank you, Chair. Thank you, Councillor McDade. Your point's well made. I wanted to just reassure you that on the basis of similar concerns that have been raised at the Audit and Performance Committee and in Audit, I had taken the opportunity at Councillor Purvis's request to write to the Chief Executives of NHS Tayside and the Council, identifying that there was a need for us to try to achieve a degree of stability of membership, and that we had been open to some criticism for the numerous changes that had taken place over the last 2 years.
Thank you to the Chief Officer for his reply, and I appreciate that he and the Chair of Audit and Performance have previously written. I'm just concerned that we are yet again facing another change, but I appreciate their work on this.
Thank you, Councillor McDade, for raising that, and thank you, Gordon, and for Councillor Purvis's comments in the chat function. I think NHS Tayside may have got the message on this, but it is, and obviously it applies to equally to Perth and Kinross Council, and we all recognise the challenges that there are in maintaining a steady membership of the board, but it's certainly something that we need to work towards and aspire to achieve going forward. And we'll be sure to make these views clear as appropriate in the various fora that myself and the Vice Chair are involved with. So thank you for your question. If there are no further questions or comments, thank you, Scott, for your report. Now, as agreed, we will now switch the agenda around a little and move on to what is item 8.1 on the printed agenda, which is the Chief Officer's report. And again, I'd ask Gordon to come in and speak to his report, please.
Thank you, Chair. And particular thanks for the kind words in your opening remarks. I too would wish to convey my gratitude to colleagues and staff across the Health and Social Care Partnership from both the Council and the NHS, and to our partners on the IJB and partners in the independent and third sector for the commitment, endeavour, resilience, versatility, compassion and professionalism that has been demonstrated throughout the last 12 months. So thank you for that, and I think it's important that we acknowledge that, because it has been very tough, and we are indebted to those who have very often, as you've said, gone that extra mile to ensure that our response to COVID mitigates its impact on staff, on services, on citizens and on communities. Hopefully members will have had the opportunity to review my report, and that may provide me with the opportunity to be fairly brief and to commit some of the time over thereafter to questions and discussions. Members will be aware that we have refined the agenda for today, and that's partly in response to the letter that John Conaghan, the interim Chief Executive of NHS Scotland, wrote before Christmas, in which he indicated that it was anticipated that the pandemic was going to result in significant demands in January and February, and there was a need for us to consider how we can ensure that services were resilient and that there was capacity in the system, and that should equally apply to staff and to senior officers. So the approach that we've taken is I suppose, around a 2 or 3 month period where we are a bit governance light, but it is important that I bring forward this report and put in the public domain and I'm exposed to some scrutiny and challenge and support from the IGB in relation to all the work that has been undertaken in response to COVID. And this report primarily focuses on our COVID response. Sure enough, after Christmas, we did experience a significant upturn in the prevalence of the pandemic, and that required us to step up our command structure, both in terms of the Health and Social Care Partnership, but within the NHS and Perth Kinross Council, and I'm on all the gold commands for the three organisations. The increased numbers may well be a consequence of relaxed restrictions over the festive period, but they are certainly a consequence of the new variant and its prevalence and virulence and infectivity. This meant that in early January we saw the numbers of people in hospital with COVID increase, in fact treble during that period, and we saw community rates, as evidenced through Public Health Scotland's daily statistics, in Perth and Kinross and in other Scottish local authorities, double and in some cases treble per 100,000 of the population. We have seen and we've experienced and we've managed and sought to mitigate outbreaks of COVID affecting community services, our community hospitals and care homes. And this has required us at times to provide staffing support to the independent and third sector in order to sustain services, and that includes council staff and NHS staff. More positively, I suppose we should recognise that we have achieved significant progress in the vaccination programme. As of today, NHS Tayside has delivered 115,000 vaccinations. That really is a really impressive figure. It represents nearly a third of Tayside population. We have initiated community clinics in Dewars and Perth and Locality and Blairgowrie, and are looking at initiating such a clinic in Crieff. And last week, NHS Tayside's performance was the highest of all mainland health boards per capita of the population in relation to administering the vaccine to the cohorts that had been identified as priority groups in the first instance. To turn to my report in a bit more detail, I would wish to just draw out some key themes. The sections that I've outlined in relation to capacity and flow, section 4, I think is important because that reflects how various parts of our system come together to ensure that we're continuing to deliver services, that we're flexing and adapting those in a way that meets the demands we're facing. But equally, those combine to ensure that we're delivering on the IGB's strategic objectives. So there are elements in this report throughout that references those strategic objectives. And it's probably important that we reflect that a lot of these activities, a lot of these service developments, a lot of the responses that we've delivered may not have been what we had planned. They may have allowed us to accelerate some of our plans, but they all do continue to combine to achieve our strategic objectives. And just to remind members of the IGB, those are about taking an approach that is a preventative approach that supports early intervention, taking an approach that seeks to address health and social inequalities, taking a person-centred approach to the delivery of care and support, and taking an approach that seeks to strengthen communities, to build in community capacity, and to help communities find their own solutions and have a higher degree of resilience. Our final strategic objective, as members will be aware, is around the best use of resources, and certainly we've sought to do that throughout everything we've achieved during the pandemic. So in terms of the specifics within the report, obviously the Care at Home section talks about how we are looking at developing a resilience project, and that is effectively how can we get a better balance between the services we purchase and the services we provide, and how can we get a better balance through the delivery of more outcome-focused services Now, one of the ways that we're seeking to do that is to think about how we can build on local cooperatives and provide opportunities for local communities to direct their own support and to be much more actively involved in the design, delivery and oversight of that support. So that's a project that's underway, and we will look to report to the IGB in relation to the outputs from that in due course. The report talks about a locality integrated care service, and again that is an investment that the IGB made to deliver on that model of care and support, and that's an essential service development that continues to thrive and develop in order to support the delivery of our strategic objectives. There's mention of urgent care, and this is about how we are designing a response in partnership with NHS Tayside to deliver on the Scottish Government's redesign of urgent care. And again, we would anticipate that that will be a report that will come back to the IGB because of its direct impact on the provision of our minor injuries services, and also the local development of care and treatment services, which are part of the Primary Care Improvement Plan. Members will see at 4.2 that there is further investment available in relation to district nursing, and we're looking at how we can ensure that we are able to avail ourselves of that and invest in ensuring that we get additional staff in to support our activities. We have, through our remobilisation plan, expanded our district nurse evening service, and that is something that we will evaluate and look to support and mainstream on an ongoing basis. Members are aware that we have had reports previously on the significant support that we're giving to the care home sector, and it may well be that Lynn Blair, who's our integration lead from Scottish Care, would wish to contribute at some point in relation to the partnership approach that we've taken in order to ensure that our 43 care homes in Perth Kinross are sustained, are supported, are informed and are engaged in discussions around how public health support can ensure that they are taking every step necessary to mitigate the impact of the pandemic. We do have care homes that at various times are closed or open because of outbreaks, and we have daily contact with those that are experiencing particular difficulty. The next section is about the vaccination programme. I've touched on that. I probably won't say much more than that. And then at section 7, lateral flow testing is being rolled out and introduced much more widely in order that we can detect any exposure or risk or infection from COVID earlier and take the mitigating action to ensure that people are able to either be tested again or to self-isolate. And that now extends to our care home services, our day services and personal assistance under self-directed support. Section 8 describes some of the activity and some of our commitment to ensure that we are working with partners in the NHS and the Council, and we need to recognise that the staff from the Health and Social Care Partnership are employed by those organisations, and they've been doing a lot of work around well-being, around support to staff, around opportunities for people to talk about their experience, and it's very clear that we need to look at how much more we can do in that regard to ensure that the resilience of our staff is protected. And one of the challenges for us is ensuring that people can get some time off, because like many organisations, a number of our staff have carried over annual leave that they weren't able to use last year. Section 9 gives an update in relation to the progress that we've made in supporting the delivery of more robust and effective community mental health services. It talks about this third sector support that we've given. We've reported in this previously. It talks about further investment into primary care mental health services. And this is again about our interventions being preventative, being responsive, being person-centred. We're working very effectively in partnership with a number of third sector organisations. And at section 9.13, you'll see that we're also advancing proposals to appoint a suicide prevention coordinator to work with partners in Perth and Kinross to ensure that we're responding more effectively, raising awareness and hoping to get to a position where we're seeking to mitigate the risk of people attempting to take their own lives. There are then sections on alcohol and on drugs. I don't propose to go through them in detail. And then, of course, what we've done this time is provide the IGB with more detail on the hosted Tayside-wide services that we have a responsibility for in Perth and Kinross. And those obviously are public dental services, podiatry and prisoner healthcare. Sections 12 and section 13 of the report are about performance and risk. I don't intend to say anything about that. Councillor Purvis will reference those, I'm sure, in his update from the Audit and Performance Committee, and 2 papers in that regard are attached to today's papers as appendices for IGB members' information. Section 14 highlights the fact that we are now working on the 3rd iteration of our remobilisation plan, the first draft of which has been submitted to NHS Tayside, who are required to pull together a composite version. There's further work to be done on that. We have identified the sections that it seeks to address, and what we would intend to do is to bring the completed remobilisation plan to the next IGB, by which time it will be fully developed and we will be clearer about the Scottish Government's response to it. Perhaps finally, Chair, I am picking up on your request that I make reference to the independent review of adult social care, which is covered in my report at section 15. And I'm keen to hear the contribution that the Vice Chair is going to make following your meeting earlier today with the Cabinet Secretary. I suppose the important thing for the IGB to be aware of is the section 15.3 in my report, which describes how the Derek Feely report, or the Feely report as it's come to be known, talks about the need to take a human rights-based approach to adult social care, to do more to support people and unpaid carers, to manage their own care, to take control, to flexibility and choice. It talks about the need to strengthen the workforce and to ensure that staff are engaged, valued and rewarded. It talks, and I think this is very positive, of the need to move away from the tendency that sometimes has existed to describe the spend on the health service as an investment, but the spend on social care as a burden or a drain. That needs to be equalised, and there is significant coverage in that report about the need for increased investment in adult social care. And as you mentioned from the outset, there are proposals that are fairly far-reaching around structural change. The IGBs should not report directly to health boards or be directly engaged in supporting health boards and councils, but should report to a national care service. That the IGB should employ some staff, although it's unclear whether that extends to all staff who are currently in health and social care partnerships, and that the IGB should include voting members from the strategic planning group, and that the user and carer representatives should be voting members on the IGB. That chief officers should report directly to a chief executive of the National Care Service, and there should be a Scottish Minister for Social Care. So these are very significant proposals, and as you've intimated, Parliament approved the Cabinet Secretary's motion in that regard yesterday afternoon at the end of the debate. Chair, I shall stop there. I'm conscious I haven't seen whether there are questions or comments, but I'm aware that there have been. But equally, you wanted to bring in the Vice Chair in relation to the matter of adult social care review.
Yeah, thank you very much, Gordon, for your what I must say I found a very comprehensive report on the wide, not just the pandemic, but the wide range of activities for which the Health and Social Care Partnership is responsible. So thank you for that report, and indeed thank you for the briefings that have come forward to members since the the previous IJB in December, and particular thanks to Jane, who I know was actively involved in the preparation of these reports as well. So thanks to her and to the others who contributed. Now, before I move on, just now that we've heard Gordon's report, if members do have questions, and I mean questions as opposed to comments, can they please indicate accordingly by putting Q in the meeting chat now, so that I may manage the time spent on the questions that have already been intimated, of which there are 4 at the moment. 1 from Bob Benson, 2 from Pat Kilpatrick, 1 from Bernie Campbell. We'll move on to others later, but we shall start, please, with Bob Benson. And Bob, perhaps you might care to. Sorry, I'm getting some interference.
I'm happy to cover the theory item as well, Chair, if you would like at the same time.
Oh, Bob, is that you that's speaking just now?
Yes.
I'm afraid you sound a little bit like a cartoon character at the moment.
I see. I'm really sorry about that.
No, I mean as in you know, it's not something that we can really pick up what you're saying without a big smile on our face. It's kind of like Daffy Duck, if you know what I mean. So maybe if we can park your contribution for now, if you don't mind, Bob, and perhaps behind the scenes colleagues can try and assist Bob in resolving that issue. I'm sorry about that, Bob. You were first in, but you know we'll need to come back to you. I'm sorry. So if I may, if I can go to Pat Kilpatrick first, please.
Thank you, Chair. And I do want to also say very briefly that thanks to Jane and Gordon for the briefings, which were very helpful and very reassuring in lots of ways. So I'm grateful for that. I've got a couple of questions. One was about the respiratory service in Gordon's report. Now, when I joined the IJB in November 2018, we spoke then, and I asked questions then. I do remember it because it was of Hamish, the clinical lead, about the respiratory service, and I was told then that we have a community respiratory service, or we were getting a community respiratory service up and running, and we had designated staff. But this looks like in the report as if now it doesn't say this is additional resource. It just talks about the community respiratory service, and I'm wondering if are we a wee bit behind the 8 ball here because we didn't get that service up and running, or did we get it up and running but it was overwhelmed by demand, or did we not have the resources to get it up and running? Because technically, if we got it up and running in 2018 with the staff that we're talking about in the report, we'd have been able to cope with that without a lot of running around setting it all up. And my second point about that one is that going to provide the rehabilitation for long COVID patients back in the community? And is it going to also provide the COVID rehab, because there will be things like physio and OT rehab that will be required? They'll also have to link into the monitoring of anticoagulants for these patients, because a lot of them will be discharged on warfarin because of the clotting effect of COVID, and also the monitoring of their oxygen saturation levels as they recover. So first question is that the respiratory service, or is this new? And will it, and if it's not, if it's new, why didn't we set it up in 2018? Second question is, will it provide the rehab for these patients, and how will it integrate? Because it has to have a holistic approach. And my very last question, actually there's 3 questions, Chair, I apologise, is in the urgent care, and what progress have we made in the last 6 months? Because I asked about this 6 months ago, in the monies that were allocated for a minor injury service, minor illness service in Perth City, and I was told at that time we didn't have a site, but I'd like to know if we made progress on finding a site. Thank you, Chair.
Thank you. Can I ask Evelyn Devine, Head of Health, in the first instance to come in with a response, and then perhaps Gordon can amplify as necessary thereafter.
So Pat, I hope I've got all your points here. So you're absolutely right. The reference in 2018 was to the respiratory service that we had agreed through the budget setting process. We struggled to recruit to that service. We had 3 rounds of recruitment to actually get staff that were appropriate. So there's quite a hold up in the recruitment to the service. So the service that has now been referred to in Gordon's report is the respiratory service that has now been recruited to and is just beginning to take shape. We've had to recruit staff that we've had to train. We've had a collaborative approach with our secondary care colleagues in order to be able to do that. So yes, so that now is the respiratory service. In relation to long COVID, I think this is part of our remobilisation plan as we speak. We need to do some more modelling around that. I would suggest that the respiratory service will be part of that, but it will need to be a much broader service moving forward with the additionality of AHP and OT and PT in particular, I would suggest. And we have the care service, which is a Tayside-wide service, as you know, for rehabilitation in relation to long COVID, and it would be our intention to build on that as we move forward. But yeah, the respiratory services is the service we referred to in 2018. In relation to the progress around Perth City, we have secured temporary accommodation for our care and treatment centre at Beach Grove. In relation to the supporting of the care and treatment activities that need to happen there, but there's still ongoing conversations around a more permanent base for that service. I don't know if Gordon wants to come in over and above that.
Thanks, Evelyn. That's really helpful, and I hope you can get the integrated rehab service up and running, because obviously these patients are being discharged now, and their needs are now, right now. You know.
Yeah.
And
the AHP service across Tayside have a real handle on this, Pat, as well.
Good. Thank you. Thanks, Evelyn.
Thank you. I don't know if you did have any further comments, Gordon, or if we can move on.
I mean, the only comment that I would make is that we might have anticipated that the Scottish Government would have extended some of the timescales for the delivery of the primary care improvement plan. And before the pandemic, they had asked us if we could, like every other area, quantify the gap between the money that had been made available and the money that is needed in order to achieve delivery. But however, there's been no communication in that regard since. So we still have to anticipate that we're working to the same sorts of deadlines, and it will be important that we establish a much more permanent footing in terms of care and treatment within Perth City. That may well be able to be realised through some broader work that the Associate Medical Director is doing in assessing and effectively carrying out a strategic needs assessment of GP provision across Perth and Kinross in the context of significant housing developments in various parts of the city, and in the context of some of the existing premises not necessarily being sustainable in the longer term. So we need to look at that in the round, and Hamish Dougal, were he not working 7 days a week trying to deliver vaccines and COVID response, would certainly have been seeking to advance that as a matter of priority. And we may begin to do so again within the next few weeks, so that will prove very helpful.
Thanks, Gordon.
You. Thank you for these responses. Thanks for your questions, Pat. And now I see we are rejoined by Bob, and hopefully it's your voice and not that of Daffy Duck this time. Let's give it a go with your contribution.
Can you hear me better this time, Chair?
That's better. That's better, Bob. Thank you very much. Good.
Thanks very much, and thank you very much, Gordon, for this very comprehensive and assurance report. Just a couple of questions. One is, you referred to the work you're having to do on Gold Command, and that seems to be not just within Perth and Kinross, but across Tayside as well. could you give us an indication of how much of your time is being spent on Gold Command, and whether that responsibility is shared out equally with other chief officers? And the second question is directly in your report, is there any overlap between the suicide prevention issue in item 9 and 9.13 and alcohol and substance use in 10? And if there is any overlap between both of these issues, are there national funds available to us that could help us, given the recent responses from government to the Dundee drugs deaths issue? Thank you.
Thank you very much, Bob, for those questions. In terms of Gold Command, at the moment, NHS Tayside Gold Command has been scaled back to 3 days a week. It was 5 days a week. And Perth Kinross Councils is twice a week, and the partnerships is twice a week. So we've scaled that right back. In terms of the commitment that it makes in my time, actually, I see it much more as an investment, because it enables me to very effectively draw very clear lines and make links between the three respective parties and ensure that our efforts are greatly aligned, supportive of each other. It provides the opportunity for me to escalate concerns that are arising, and it has yielded significant benefits in terms of both the Council and the NHS providing support to the partnerships, and vice versa at times. So I think it's well worth me spending my time doing that. I do it though on behalf of the three chief officers, so I am also regularly in touch with Gail and Vicky in that regard, and we tend to cover for each other if I'm unable to do that. But Gail and Vicky are members of Silver Command, so there's a bit of a segregation of duties there, and we work really effectively as a team. The other thing that was a product of was the recognition that Vicky is the chair of the Chief Officers Group nationally, and similarly Vicky needs to commit some of her time, albeit it is always less of a priority than her local COVID activity, on national groups. But similarly, that's delivered great benefits for us within the Health and Social Care Partnership and within Tayside, because Vicky Irons is on the Scottish Government's Gold Command, for example, and we can quickly get feedback and information and also escalate issues. So I acknowledge your point. It's never been something that I've had any difficulty with, either in terms of capacity or in terms of understanding the benefits that it brings. So it's been okay, it's been good. Your other question is absolutely valid. You know, the relationship potentially between alcohol, substance misuse and suicide, and mental health and suicide. So we are looking at how we can redouble our efforts to establish the extent to which there are any links, but whether there are links or not, our commitment is to put in place effective services that ensure that responses are available, that they're joined up, that they're accessible, and that they're reaching the people who might not otherwise have come our way because people have been affected by the pandemic, or the people in parts of Perth and Kinross where we don't traditionally or haven't been able to traditionally offer services. So we've sought to address that through our existing commitments, through our core funding, our commitments through the use of Action 15, through probably a couple of £100,000 that we've put through our remobilisation plan to pass on to third sector organisations to provide enhanced community support, and also through the funding that's available through the Government Choose Life campaign. And that's where we're looking at how we can build on that to develop the Suicide Prevention Coordinator post. However, very recently we learned from Scottish Government that additional funding has been made available and will be forthcoming in relation to their response to drug deaths. And we will be actively looking at how much of a share of that comes to us, and obviously then how can that be best deployed in order to fill any gaps in our service provision, develop our approach, or bring in new services and new models of support.
Thank you.
Thanks for these answers again. Okay, moving on. Next up is Bernie Campbell. Bernie, can you ask your question, please?
Yes, thank you. Hopefully you can hear me. My question is in regard to point 9 of Gordon's report, and it's in relation to the mental health and wellbeing strategy, and it's regarding mental health services, where patients remain in assessment wards for an extensive period of time due to the lack of suitable accommodation in care facilities within the community. My question is, one, do we know how many patients find themselves in this situation? 2, why is this the case? And 3, has this been addressed as part of the strategy? Thank you.
Thanks, Bernie. Gordon? You're on mute.
Sorry. Bernie, I didn't catch the first part of your question in relation to which group of people were you describing, sorry?
Sorry, Gordon, it was in relation to the mental health services. So it was point 9 of your report, mental health and wellbeing strategy. So regarding patients who remain in assessment wards within Murray Royal Hospital for extensive periods of time due to a lack of facilities within the community for them. And I was just wanting to know, do we know how many patients that fall into this category, and why is this the case, and has it been addressed in the mental health and wellbeing strategy?
Okay, thank you. So I'm getting a bit of an echo here. Thank you.
Say that, hello? Could I just mention that it's Bernie is specifically...
Maureen, sorry. No, can you? We've had a question from another member, and it's it's for Gordon to reply to that.
I was trying to point out the psychiatry of old age that Bernie is referring to, not general adult services. It's psychiatry of old age that are blocking beds. Okay.
Yeah, thank you, Maureen. Can I just? I mean, I'm not trying to be difficult or anything, but it should be either or. Of yourself or Bernie on this call at the moment. I know that Bernie's leaving at some point, and so that's fine. I'm quite happy to be flexible as I can. But if a member asks a question, he or she deserves an answer, and I appreciate you're just trying to clarify. But if I can ask you just to restrict your interventions until you're invited to do so, that would be helpful. Thank you.
Thank you very much, Chair. Thank you for your question, Bernie. Yes, I understand that to pertain to psychiatry of old age, and we have a challenge locally, but I think we've got a challenge nationally in relation to the lack of EMI beds, as they're described, or continuing care beds, which the NHS in Scotland no longer provides. So what it is, it's really important that what we do is we are absolutely clear about the admission criteria for people who come into psychiatry of old age beds, and that we also immediately begin to think about how we can provide support for people either to remain there safely and effectively for as long as is needed, but to discharge plan and to be able to identify alternative, more suitable accommodation for people who don't require to be in hospital. And often that might be in specialist care home provision, of which there is a bit of a dearth. So there are a number of aspects around that. Firstly, we are carrying out a review of our population needs, of our demands and of the admission criteria, and of the need for services that might prevent admission to hospital for those people, or that might affect a swift supported discharge to enable them to remain in hospital for as short a period as possible. What we're also doing is looking at in the context, as you've described, of the Tayside-wide strategy, is to think about ageless services, and to think about how we need to ensure that the level of provision and the accessibility to services is no less for people who happen to be over the age of 65 to those who are under 65. And that requires us to work with colleagues across Tayside. There is a debate going on about whether we should have a single psychiatry of old age service pan-Tayside to manage economies of scale and ensure that our consultant workforce and specialist staff are deployed as effectively as possible. But that's very much a strategic review that is being advanced, and we're supporting that both through Chris Lamont, who leads on mental health, but more so in this case through Lindsay Bailey, our locality manager, who is advancing this work on our behalf. The numbers are very small, but the numbers are people who need to be somewhere else. They need to be cared for in a different way. They need to be enjoying a different type of experience. So when their discharge from hospital is delayed, it is important that we see them more than just statistics, and recognise that there's a human cost and an importance for us to ensure that we are taking the necessary action to address that. In terms of these more specific questions about the provision of health services, we'd always create the opportunity, should she wish to come in, for Evelyn to expand on my answer. But I'm sure she's going to assure you that I've given a very good answer, and she's probably not got very much to say.
Evelyn, you have that opportunity.
Yeah, Gordon, I think you're absolutely right, and I think just to maybe just expand slightly, and then it's sort of a reassurance to Bernie, is that this has been looked at Tayside-wide, as you've reflected, Gordon, in relation to the mental health and wellbeing strategy for Tayside. We are seeing a difference in the complexity of presentation for people presenting into our assessment wards, and you know, there remains a complexity of stress and distress that takes many, many months to manage. So we are entering into a transformation programme that will allow us to look differently at our wards and what they provide, and also into the community in terms of what level of complex arrangements that we need going forward. So it's on our radar, it's been looked at, and just a reassurance that it's not just in P&K, it's Tayside-wide.
Thank you very much.
Okay.
That's great. Thank you.
Thank you, Bernie. Councillor Duff.
Thanks, Chair. My questions also relate to Section 9, and members are aware, I'm sure, of the current mental health situation under the COVID-19 pandemic, and also about the instances of suicide and self-harm. So my question relates to 9.8, the mental health linked GP, and 9.14, the suicide prevention coordinator, which I think are two key appointments in our mental health strategy. I was wondering how these are progressing, and is there a timescale for getting people in post?
Thanks for these questions, Gordon.
Thank you. So I'll bring Evelyn in, and I think we've got some provision around GP practices at the moment, Councillor Duff, and we're just looking to expand and develop that. And I think also the suicide prevention coordinator will provide that conduit, signposting, brokerage, convening groups of all interested people across multidisciplinary around a range of disciplines. I mean, probably what I would say in the context of the IGB's strategic oversight of this is that all these individual measures, operational developments, will come together in what we think is going to be a very robust community mental health strategy, where we will look at people's journey through the system, look at doing a gap analysis, look at the demography, and we will now be looking at this through the lens of COVID, as you've indicated. So to assure you that will be reflected in the community mental health strategy that Chris Lamont is working on with partners and with stakeholders, and all these individual more operational items as described in section 9. And I think it is telling that members of the IGB are very interested in section 9. I think that shows a strong commitment to mental health and an appetite to be assured about that. These will all feature in our community mental health strategy. So hopefully that's the beginnings of an answer, but Evelyn might want to add to that a wee bit, please.
Thanks, Gordon. Yeah, I think just to reassure the board and Councillor Duff that the proposal for the mental health GP is very real and progressing through the system as we speak. We have appointed more recently a lead clinician into secondary care for mental health services, which is really good news for us. And our sense of having a secondary care consultant and a primary care GP working together and working through the clusters of GPs to improve access, which was one of the things that we really wanted to achieve, was access not only just from community to primary care, but from primary care to secondary care. And there's a real appetite with our new lead clinician to really improve the pathways and support and review that moving forward, so that we don't have duplicate referrals and et cetera, into different services. So really streamlining access is one of the key components that we're trying to achieve there, and really raising awareness of that. So yeah, we're definitely progressing that as best we can.
Thank you, Gordon and Evelyn. Is that okay with you, Councillor Duff?
Okay, thanks, Chair. Yes, thank you.
Thanks. Okay, moving on. Councillor McDade.
Thanks, Chair. I wanted to pick up on the Chief Officer touched upon the outcome of the Parliamentary Committee's report, and I think there's obviously a lot in there to unpack, and I appreciate that he and others won't have had time to fully consider the impact of it, but I think there's quite a lot of welcome changes that are proposed within it. But I'm wondering if he can give us a brief perhaps view of his own as Chief Officer of Perth Kinross IGB, what he thinks are likely to be the easier and more problematic parts to implement for us, because obviously we have we have perhaps differing issues from other areas, as indeed they will have from us. So I'm just wondering if he can perhaps give us any views of his in terms of what he thinks are likely to be our bigger challenges, perhaps, in implementing some of this.
Okay, if it's okay with yourself, Councillor McDade, what I'll maybe do, given your question, is ask Gordon to comment very briefly, and then on the back of that bring in Bob Benson to comment on our discussions on this subject with the Cabinet Secretary earlier today, and we can just cover this topic under this question. Thanks, Gordon.
Thank you, Councillor McDade. Thank you sincerely. That's a tricky one, and the reason that for me it's a tricky one is I have to acknowledge that there are a wide range of views, and this report has been received generally very well by the majority, but there's a much more nuanced approach, and I need to reflect that I am speaking to you as a Chief Officer, and the Chief Officers Group in Scotland have a view on this report. I'm speaking to you as a social worker. Social Work Scotland have a view on this report. I'm speaking to you as a council employee. COSLA have a view on this report. My own view, for what it's worth, is that we need to absolutely welcome the focus that this is bringing on the delivery of a human rights approach that supports investment in social care and will enable whoever is providing the services to better provide high quality care that protects the rights and promotes the interests of people who need services. I think we have to welcome the fact that it seeks to bring significant additional investment. I think we have to welcome the fact that it talks about the introduction of a more collaborative approach to commissioning, working with providers to co-design solutions rather than reverting to a competitive tender where sometimes price is more important than quality. The investment in social care, the focus on all those other activities, all those other priorities, for me, and this is a personal view, doesn't help me understand why structural reform is then necessary, because I think Derek Feely has absolutely nailed it when he says there has been significant lack of investment in social care and significant additional investment in the NHS over the last 2 or 3 decades. I would wonder whether, if that investment was forthcoming, this lofty ambition and the policy ambition of the rest of his report could be realised without necessarily us having to reform the current arrangements. The current arrangements may well be able to be enhanced, improved and developed. However, I think it is also encouraging that consideration is, for example, being given to directly funding IGBs, because we know that the negotiations that we have to take place with statutory partners is time consuming, is challenging and doesn't necessarily could be better. That time and commitment could be better used doing other things. I'm interested in the fact that, having done his diagnostic and his analysis and having brought forward all these other policy proposals and objectives, he has arrived at a conclusion that the best way to fix this is to create something like the National Health Service, but to call it the National Care Service, where you have a Scottish Minister, you have a Chief Executive, and you have IGBs reporting to the National Care Service, and not potentially then working as closely with 32 local authorities and 14 territorial health boards. I'm not understanding that, and that's not a criticism, that's perhaps a failing on my report, or a limitation of the report, failing on my part, or a limitation of the report, because a lot of the detail will have to be worked through. I do note, however, that Derek Feely has also suggested that one of his recommendations is that Scottish ministers should be allowed to vary the number of IJBs without reference to legislation. And I would wonder whether or not, if there were ultimately to be 14 IJBs rather than 32, that would enable those IJBs to respond as effectively as we do at the moment to the needs of Aberfeldy, to the needs of Kinlochranach, to the needs of Kinross, to the needs of the local community. And that would be genuinely a concern for me. But I should probably qualify this as these are my personal views. Others will have different views. And I think that they're all healthy views to put into the debate as we move this agenda forward.
And if I may just interject at this point and just say, this is, there was barely a reference to this, I think, in Gordon's report, and we are focusing at this point on Gordon's report. I mean, this is obviously a very, very important issue that is coming into the public domain and is very much a hot topic for discussion, but we could spend the rest of the day talking about it very easily, and I'm anxious that we don't. But if I can just ask Bob Benson to give a flavour for the discussions that we've had today with the Cabinet Secretary, and then we'll park this conversation just now. We may come back to it very briefly under comments after the other questions have been raised. So, Bob.
Thanks very much, Chair. This was a very well attended meeting with the Cabinet Secretary and Councillor Curry from COSLA. I counted about 42 chairs and vice chairs represented there, covering the breadth and width of Scotland. The meeting was conducted in two parts. One was on existing governance, and some of the questions that the Cabinet Secretary has been raising for a while around about what were the elements of the existing arrangements that were working and what bits weren't working. And one of the key issues that she has been focusing on has been around about duplication of effort with other areas of activity, particularly around the difference between clinical care governance and care governance, but also just generally about the looking at the overall bureaucratic apparatus, and I'm using that term, she didn't use that term, as to whether that could be more streamlined, given some of the benefits that I think the chief officers had reported over the pandemic period, where they had been able to be a much more fleet of foot, I think is probably the best way to describe it. So that was quite a discussion in itself, and of course there are lots of very different integrated arrangements across Scotland. I think one of the key points for me was that the difference between integrated joint boards is that they look at things not necessarily from a service point of view, but from an integration point of view. And I think that was a really quite an important focus for thinking ahead. The other part of the discussion was around about the independent review of adult social care. And clearly, there's a lot of positives in that, as I think anyone who's read the report would probably wish to see particularly human rights approach, the individuals being at the centre of their care, and the need for services to wrap round about them. So there's a whole range of stuff in there. Obviously, a lot of the discussion would have been inevitably around about structures and finance, and looking ahead. And it's worth saying here is that at the end of our discussion, when the CAB Secretary was summing up, she said that what she would be encouraging all of the integrated joint boards to do between now and the 14th of May is to actually consult together, as well as individually, but consult together with your relevant local authority and relevant NHS board to look at what do you want to see across the piece, because clearly the FEELI recommendations have implications not just for integrated joint boards, as they clearly do have, but for local authorities and for NHS boards as well. And I think that's the opportunity, Chair, that I think we will take this forward with both the leaders in local authority and with NHS and within the IJB to look at how we can perhaps do something together before the 14th of May. But I think also it would be quite helpful perhaps if the Integrated Joint Board itself has an opportunity separately perhaps to look at this as well. And that's all I really want to say. Thank you very much.
No, thank you. And that last point of yours is very important. You know, this is such an important area. And as I say, we could talk about it all afternoon, but we must not do that because of the agenda and the relatively restricted time frame that we have. I wanted Bob to bring members up to date with regard to what was discussed today, and emphasise that this is the current direction of travel without in any way prejudging the outcome of the Scottish elections on the 6th of May, but it is important to realise that this is already a train that is moving out of the station, and you know, we want to get on board and be part of the discussions that will begin to take place over the coming months. And what I would propose to do is, you know, once we've had a bit more time for Bob, myself and Gordon to get together initially to chat how best we can bring this forward, and you know, and who we would how we would bring this forward and ensure that all members are afforded the opportunity to contribute on their views on the matter. And I'm conscious that members have indicated a desire to comment at the end of this question session, but please a sentence or two at maximum, because we are already pushing the time available here. But thanks for your question, Councillor McDade, for now, and we'll move on to Councillor Purvis. Thank you.
Sorry, Chair. Councillor McDade's comment obscured my ability to unmute and
it's annoying, that, isn't it? Yeah.
Carry on. So thank you for that. Two questions, if I may. The first one is on care at home. So I'll ask them separately, if that's all right. Thank you for your update, Chief Officer. A lot of good progress in there, despite the challenges that we have been facing. One of the things that I was particularly interested in was the reference to the project that you're looking to undertake to look at more community-focused ways of delivering care at home, and possibly exploring further some of the cooperative models. And this is something that I've raised a number of times in the past and suggested ways for doing that. I was just wondering if you could perhaps give more detail. Are we looking at setting up cooperatives in other parts of Perth Kinross? How would that be funded? Would we be able to support that financially? If you could just maybe give a little bit more detail on that, please. Yeah, so I mean, I think it's of significance and is potentially quite innovative to the degree that we would certainly be wanting to bring a report to the IGB much more fully on that ambition to create a different approach. I suppose it stems from the concerns that we've experienced around our ability to attract care at home providers into some parts of Perth and Kinross, and that's to do with recruitment and rurality. We already do provide a market supplement to encourage that, in order to ensure that some people, some areas are able to get the services that they might not otherwise be able to get from the commissioning activity that we undertake. So just to remind members, I suppose it's probably quite important to reflect that Perth and Kinross Council, or the Health and Social Care Partnership on behalf of the Council, unlike many other areas, doesn't have an in-house care at home service where council employees are deployed to provide care at home. What we do have is a re-ablement service called HEART, and that enables people to come out of hospital or to recover and to be re-enabled in order that they don't need the level of care and support that they might otherwise need. It supports early discharge from hospital, and it enables people to retain independence. What we then do is we pass on the care needs for these individuals, if they need continuing care, is passed on to the independent sector, and there's probably about a dozen independent sector providers who are on our contracting framework, who provide services for us the length and breadth of Perth and Kinross, or rather not the length and breadth, and that's why we're having to look at other models. The model that we're describing at the moment is based on something called the Boleskine model, which was developed in NHS Highland, and is really about an approach that enables community-led recruitment, deployment and oversight of staff who are employed either by the partnership or through the cooperatives, to meet the needs of local people, organised locally, overseen locally, delivered locally, but funded by the partnership. And it really is a model that builds on that idea of social community capacity. It builds on the idea that there are already resources and groups and services in communities that can be built on, and it's about enabling people to remain connected. So we've been doing a bit of scoping work, and we've been looking at other models. We had looked at something called the Buurtzorg model, which is a model that has attracted some attention in the UK, and it's based on self-organised teams. It comes from Holland,
It's around teams without necessarily a management structure, who have a group of people who they provide services and support to, and they organise how best to do that on the basis of local decision making. That seems not to be taking off in Scotland despite a number of pilots, so this other model was their preferred approach. I would prefer, perhaps, Councillor Purvis, if we could provide you with, and other members with a report on this in due course, but just to provide that assurance that it's one approach that we're looking to develop. It is likely to be tried and tested before we think about rolling it out much further, and we're engaging with local community groups as part of our co-production and design activity.
Okay, thank you very much, Chief Officer. That all sounds very encouraging, and I look forward to the report, which I see is scheduled to come in June on that, so that will be good. The second question is returning to the issue of mental health, and while I know we have made some significant progress in terms of the new strategy that's now been agreed and progressed, it was in relation to some press coverage on 2 deaths in inpatient services. One was in Carsview, reported in the Evening Telegraph following a discharge, and one was on at the Morden ward after an incident where a woman sadly died at Murray Royal Hospital. Obviously, that's a particular concern, given in that ward we had a previous instance where NHS Tayside had admitted guilt with the death of three women in that ward as well. So I'm just wondering if you can give assurance on what is being done to address any of the learning from those sad events that have happened, and how we can ensure that such deaths don't happen again.
So absolutely, these are particular tragedies, and we have to be concerned about the circumstances and ensure that we pass on our condolences to family members who are affected. The leadership in relation to the provision of those services, as we know, transferred when operational responsibility was taken back into the NHS, and my understanding is that the colleagues who are responsible for the oversight and the delivery of those services are actively looking through the LAIR process, the local the local adverse event review process, what circumstances were, what contributed, what lessons can be learned, what additional support might be needed, and how we can develop an approach that is contributing to ensuring that these sorts of situations don't arise. I probably would just wish to comment on the generalities of these cases, particularly because there may be ongoing police investigations given the circumstances. And my information beyond the media coverage that I've also seen, Councillor Purvis, is around a real concern within NHS at what can we do to ensure that we do create an environment where these situations are greatly reduced and hopefully eradicated, and how can we learn from these particular situations to ensure that the service response is as effective as it can be, albeit there are sometimes sadly circumstances where no matter what people try to do, people will sadly complete suicide. But I probably wouldn't want to be drawn in that any further.
Okay, thank you.
Okay, thank you, Gordon. Ronnie Erskine. Ronnie.
Thanks, Eric, and thanks again to Gordon and Jane in particular for pulling this together. As you've heard me say before, no one or nothing is more important than our staff, our frontline staff, in the delivery of all of these services, and also Gordon and your team as well. Of course, it's critical that you're in place and able to deliver the strategic overview, as well as make sure the operations happen on the ground. So I'm quite conscious that some of the experiences that our staff will have experienced over that past year may have been quite traumatic and have impact on staff in the longer term. And I recognise in paragraph 8 on staff wellbeing, it's something you've very much got your eyes on, and there are various measures which we are taking to address this, both in the short and the long term. What I wondered, because you refer to HR in here as well, I wondered if you could say a little bit more about really is what kind of HR steer we're getting and what kind of particular priority actions we're taking to make sure not only that we support staff now, but also that we're able to identify when staff perhaps start to fall over as the pandemic hopefully eases over the coming months. Are we well prepared for that? Are we well sighted and able, have we got plans in place to deal with some of that? Let's hope that we don't have too many issues, but I'm looking for a bit of reassurance on that. Thanks.
Yeah, thanks very much, Ronnie. Absolutely, this is a really important area for us. It builds from the local line management responsibility, where staff are supported in their teams by their managers, and managers are attentive and engaging and just checking in with folk. It includes the additional support that has been advanced through these wellbeing champions and resources that have been made available at a local, a service-wide and a national level in terms of emotional health and wellbeing and building resilience. It can simply be around the need for us to ensure that people are taking annual leave and taking time off and supporting people by covering jobs in order that they can do so. Within NHS Tayside, it has particularly been a focus of the employee director and the director of HR or organisational workforce, and they've been looking at what services and supports can be provided in, particularly in hospital sites, in order to ensure that people can have rest and recuperation and can have time out. And they've also done some audit and survey work around what provision might be beneficial to people in order for them to themselves feel that they're valued and supported in a different way. And that's been everything from looking at the provision of bottled water in some wards in order that people can get a drink between seeing patients, and some simple practical solutions like that, as well as the broader support that's available through pastoral and spiritual care and emotional well-being support that's extended. I do agree with you that we need to continue to focus on this, and I do agree with you that we need to anticipate that there may be a delayed reaction for those people who are currently immersed in response mode, and when we get to a different position in terms of COVID's prevalence and we're able to get a bit of breathing space, that might be the time when it has its impact. So yeah, we will continue to look at that. I mean, I think in terms of our staff, absolutely there is that risk, but I do wonder and I do worry whether nationally the country is going to experience a bit of PTSD about COVID, and absolutely, you know, the Scottish Government have been front and centre at looking at how mental health supports can be enhanced and supported, and I'm sure will continue to do so, because in as much as it affects our staff, it obviously also affects ourselves, our citizens and our families, so it's going to be a wide-ranging consideration moving forward, and we certainly stand ready to avail ourselves of any resources or opportunities that come from the government or from our statutory partners, because this will probably be, you know, something that will have a significant aftermath in relation to our experience of the pandemic. Evelyn's put her camera on and may want to say a wee bit more about that.
No, Gordon, I think you've covered probably what I was going to say. I think from a HR perspective, I think there needs to be probably further consideration given to the compassionate way that we apply policies and procedures, including promoting attendance at work, phased return to work after bouts of COVID, and you know, we're trying to do that already, obviously, but it's really getting the sort of academic sense around that to maybe, you know, soften some of the approaches that we have. And I think that would be really important to supporting people back to work. But that is our line in terms of a management line to our staff that have struggled through COVID and returning to work, or have struggled in other ways dealing with more end-of-life care than normal. I think it's really important that we use compassion in relation to applying our policies and procedures, and I think to be backed up by HR would be a good thing in that. So it's not to say that we don't do it, because we do, but you know, I think maybe adjustments of policies might be relevant in some cases.
Okay, thank you, Gordon and Evelyn. Is that okay, Ronnie?
That's great, thank you. Thanks.
Okay, good. Right, thank you. There are no further questions on this item in the agenda. You know, we have had 55 minutes of questions and answers there. I'm going to allow a further 5 minutes for any comments that members care to make. There are 4 people who have indicated so far their desire to comment, so I can ask you all to be brief, and we'll start with Councillor Purvis and then Sandra Auld. Councillor Purvis.
Thank you, Chair, and I'll try to be really brief. It was just on the Feely review. I think there's some excellent stuff in that in terms of the standardisation of the quality of care, voting rights for SPG, carers and service user representatives. I think that's all very positive, and trying to bring social care up to the same parity of esteem as healthcare. I also think direct funding of IGBs would be a really good step forward. I do, however, have concerns about the structures, as the Chief Officer alluded to. I am concerned about the lack of local oversight that would happen if some of these reforms are implemented, and I would be keen as an IGB, as you've already indicated we will be able to do, could look at how best we can respond to that, because I think that the needs of people within Perth and Kinross are very different to the needs of people even in Tayside or indeed across the whole of Scotland. And while some of the things in this review are very positive, I would not like to see any diminution of local decision making and ensuring that we best meet the needs of our local communities.
Thank you, Councillor Purvis, and I would just, and Mr Benson will back me up on this. That point you just made about the difference between the rural oblique urban nature of Perth and Kinross versus purely urban areas of Scotland is the precise point that I made to the Cabinet Secretary this morning. So we're on the same wavelength there. Thank you. Sandra Auld, thank you.
Thank you very much. Again, another comment on the review of adult social care. Something that I had highlighted to the group previously, the potential importance of that, and urged the opportunity to be made for the board to have discussion as a group around this, about both the opportunities and the potential threats included in it. For those that may be interested, the Health and Social Care Alliance on the 22nd of this month at 10 in the morning have an opportunity for discussion and questions with Derek Feely for anyone who might want to avail themselves of that opportunity. You could link into that or register for it via the Health and Social Care Alliance website. Thank you.
Thank you for that, Sandra, and yeah, perhaps if through Valley, can you perhaps circulate that opportunity, that would be helpful. I'm noting a comment that okay, we'll come back to that in a moment. Councillor McDade.
Thanks very much, Chair, and I just wanted to thank Chief Officer for his honest comments, which was what I asked for, so I'm very grateful to him for that. And I think it would be very helpful to have a session, a development session from the board to consider how we might respond more formally the outcomes here. And I think I echo a lot of his concerns, and also the more positive aspects that he was commenting on. I think particularly around geography, which is often easy to forget, but not for those of us that live in the rural extremes, perhaps. So I think he's absolutely right about. I'd also like to not see us go backwards, essentially, in terms of the point here was to get greater integration of health and social care, and I wouldn't want to see anything come in that actually would be regressive in that direction. But I think there is a lot of positive outcomes in it, and I think it would be very positive if we can have a good development session, and I think it's important we schedule lots of time for that to consider it, because this is a really big topic. But that was all.
Yeah, no, thank you for that, Councillor McDade. And again, just referring back to one of the Cabinet Secretary's specific comments this morning, where she said that it has to be, we have to take all steps to avoid unintended consequences, such as you've described. So that again is very much in the minds of those involved. Sandra Gourley.
Thank you. It was just really a comment, probably relates to both the remobilisation and the mental health aspects of the report, and it's just a reflection around the opportunities for us to consider the development of mental health advanced nurse practitioner roles and the benefit that they can bring across that agenda, particularly from a mental health perspective. There is a significant amount of work going on across Tayside just now in developing the frameworks that need to be in place to support advanced nursing practice. So it's just a reminder really that of the benefit that these types of roles can bring.
No, thanks for that, Sandra. That's appreciated. Now, before we go to, we're going to take a short comfort break given the time. But I know Maureen Summers has asked to speak, and that's perfectly in order. Maureen, apologies, I had taken from the comments that you were looking to speak on item 9 on the agenda rather than this item, but apologies if I'm mistaken. Feel free to make your comments on this paper. Thanks.
I don't have a facility, Eric, to raise my hand here.
No, nobody does, Maureen.
All right.
Because this is a Q or C.
Right, I'm using a laptop that I'm not familiar with. I'm up at the carer centre because I can't access this meeting through my iPad. So sorry. So I just put in the chat that I wanted to speak or make some comments and ask questions on item 9, but I don't know if you were seeing that or not. So
item 9, yeah. Okay, so yes, and I will come back to you when we get to item 9. Thank you. Right. Okay, well, in that case, if we can at this point take a short comfort break, and I will return in 5 minutes time at 2:47. Thank you. Okay, hopefully everybody has managed to take a quick break, boil the kettle, etc. And we're back at our desks, and if we can now move on with the rest of the agenda. Firstly, just to note for the record that first of all that Bernie Campbell has left the meeting at 14:22, and her place is taken by Maureen Summers, and also that Councillor McDade has left the meeting at 14:43, and so we are nevertheless obviously still quorate, so we shall progress with item 7.1 on the agenda, which is the 2021 financial position, and if I can ask Jane Smith, the Chief Financial Officer, to speak to our report. Thank you.
Thank you, Chair, and good afternoon, everybody. Members will note in the report before them today, perhaps with a level of anxiety, the significantly increased forecast underspend on our core services. And perhaps most notably, the £2.2 million forecast underspend on social care services, which has increased significantly since the last report. There is no doubt that COVID and the significant ongoing lockdown restrictions are having an impact on levels of core expenditure across almost all social care services. In particular, our adult services are forecasting an underspend of £728,000, resulting from delays in the commencement of packages and the reduction in the use of respite and transport. And for older people services, usage levels and essential changes to service models are driving an underspend of £573,000 across day services, carer support, equipment and short breaks. In parallel, for care at home, a significant underspend of £620,000 is forecast, reflecting significantly less hours being provided than provided for in the budget. However, IGB members may remember that care at home underspent by a very similar amount at the end of last year, and it's that level of underspend or an inability to provide hours in the planned way that we had expected that has led to the care at home review that we have been discussing under the last agenda item. Within our health budgets, the level of forecast underspend is now entirely offsetting our core deficit, and again we're seeing a level of underspend in almost all services. For our bed-based services, including medicine for the elderly, psychiatry of old age and our community hospitals, we are forecasting a net underspend of £97,000, and that's widely different from the £800,000 overspent that we incurred in the last financial year. For bed-based services, the ongoing implications of COVID and lockdown and an overall reduction in unplanned admissions into hospitals and reduction in delayed discharges has reduced the intensity of demand across bed-based services, reduced the spend on supplementary staffing, and that sits alongside a general increase in the difficulty to recruit to posts because of the uncertainty that COVID brings in terms of the health and social care landscape, and an unwillingness of staff to move at this time. Slippage of almost £500,000 on planned investment is also contributing significantly to the underspend on health due to delays in recruitment and slippage in wider transformation review work. We talked earlier about the impact that those kind of delays have had on our respiratory service, and also in terms of our, it's also with regard to our intermediate care bed provision, which we've not been able to progress. Of course, what we have to realise is that across all of our services, the actions that we're taking to mitigate those impacts are included in our COVID response. They're included in our mobilisation plan, and those costs which were not budgeted for are included in our COVID forecast. Those include, for example, £740,000 of additional staff spend, not budgeted for, but still supporting our services as part of our COVID response. £533,000 on additional bed capacity, again stepped up as part of our COVID response, and also additional spend on mental health services, care home support, discharge coordination and wider community provision. So whilst we're reporting separately on our core services and our COVID response financially, it's impossible from a service perspective to disentangle these, and our COVID response goes hand in hand with what's happening on the ground in relation to our core services to ensure safe service delivery. IGB members will, of course, wish to understand at the earliest opportunity the longer term implications for the shape and scale of service provision, both for bed-based services and community services, and the financial implications of those. We fully recognise that, but by necessity, we can only bring forward a one-year financial plan and a one-year 21-22 remobilisation plan, which will come forward to the April meeting. And this one-year approach is fully in line with Scottish Government guidance, and that longer-term planning can only resume when we come forward and emerge from the ongoing emergency footing. Despite that, we've referred to earlier today, despite the ongoing intensity of our COVID response, my colleagues across the partnership continue to progress some of the most fundamental key service reviews that we've undertaken over the last 5 years. The review of care at home has progressed at pace over the last 5 or 6 months. A review of our adult complex care provision has progressed over the last few months, and we have progressed the community mental health strategy also in very difficult circumstances, because we recognise the importance of all of those reviews in terms of safe, sustainable and financially affordable services moving forward through a COVID lens and taking the learning of COVID. In terms of COVID response and cost themselves, you'll see that those costs have increased, the forecast costs have increased, largely due to increased bed capacity stemming from the Tayside plan and escalation of the need for additional beds in January. At the time of writing this report, £6.7 million of additional income had been received from the Scottish Government, with a further £3.1 million anticipated. As of the 5th of February, we now know that the Scottish Government will give us £6.1 million additional funding. That's significantly more than we were anticipating and we require to meet our forecast costs. And for many health and social care partnerships in this position, where we have more funding than costs, there is an absolute expectation that that funding will be carried forward as a COVID reserve to meet COVID costs in the next financial year. And for Perth and Kinross, that amount is expected to be £3.978 million that will be carried forward into next financial year. In addition to COVID funding, the Scottish Government have announced on the 5th of February the creation of a Community Living Change Fund. The Perth and Kinross share of that will be £500,000. This will be carried forward, and we will work together to understand the best use of that resources over the next 3 years to support complex care. The Scottish Government have also announced additional funding to reduce drug deaths, which Bob referred to earlier. Our initial share of that is £67,000, and discussions are already taking place around how that will be utilised, with significant more funding still to come. In terms of reserves, and I note concerns from IGB members in previous meetings that our inability to reduce the level of reserves. Unfortunately, and in parallel to all HSCPs across Scotland, the pandemic has an impact again on our ability to take forward our planned actions in relation to the utilisation of our primary care reserve, our ADP reserve and our Partnership Transformation Fund reserve. That funding will be carried forward and will support our existing commitments and priorities as they've been set. And we will add to that the £3.978 million COVID reserve that we will now carry forward to meet COVID funds into next financial year. I'm very happy to take any questions.
Okay, thank you, Jane. Thank you for that comprehensive report as always. If you have a question, can you please put a question in a queue in the chat function now, and I'll come to you as quickly as I can. Ronnie Erskine. Ronnie.
Thanks, Eric. Thank you, and thanks, Jane. It's welcome to hear the £4 million potential carry forward for COVID for next year. That is assuring, quite reassuring. What I'm particularly interested in when I read these reports is the link between finance and performance, and I look at underspends as much as overspends. And what I wanted to ask you was about two particular areas. If I can find them in the paper, there's 4.2.1 related to prison healthcare, where we've got a level of underspend in there. I wonder if we could provide some reassurance that hasn't impacted too much on the recipients of that service. The fact that we're underspent, do we have any concerns in that area? And the second question I had on going back the way to 4.1.1 was the overspend in the last bullet on psychiatry of old age, £0.4 million for inpatient services. I just wondered if you could say a little bit about the reasoning behind that overspend. Thanks.
Well, if I could ask Evelyn to respond first of all in relation to prison healthcare and concerns about sustainability.
Yeah, thanks, Jane. Evelyn.
So, yeah, in relation to prison healthcare, this is a service that historically has quite a high vacancy factor. As you can imagine, it's a difficult to recruit to area, and it has peaks and troughs, let's just say, in terms of good and bad. But we have a regular commitment from the HSCP and Gordon as Chief Officer to provide regular agency shifts into prison healthcare, so that we have people who are key trained, who know the job, etc., etc. So that's a regular commitment. We've had to up that more recently during COVID times, and that's been funded through COVID funding, as it's particularly related to some staff who have not been available either due to COVID themselves or to longer term sickness. So yeah, it doesn't particularly impact on the service itself. We do have some ongoing issues which we're trying to deal with currently, and that is around primary care, GP input into the prison, and looking at different ways to actually provide that in a more creative way. But these are things that we're sort of working on at the minute. But in general, we have, although it sits as a red risk in relation to vacancy factor, it's well covered, Ronnie.
Thank you.
In relation to psychiatry of old age, so that has been historically overspending year on year for a significant period of time. We're talking quite high overspends, around 300,000-400,000. Jane probably give you the exact figures. So in relation to that, we again adjusted some spend in relation to the fact that they were one of the first services to support COVID in their wards. And we did put a sort of bid into the mobilisation plan to enhance staffing around that. So again, we had some staffing that supported that in relation to, although it's still carrying an overspend, it's a lot less than it would have been in normal times.
I guess the follow up there, is the budget a realistic one in that area if it's been overspending for several years?
So that's a piece of work, Ronnie, that's ongoing at the minute. So it's not just the budget, it's the actual type of service we're delivering in there. And I would suspect, as we talked earlier about the complexity of the patients that are now in the wards, that it's a completely different model we need. But I believe that's potentially a Tayside discussion, and with the health board as well, because it may be we're commissioning a different, more intensive unit for older people in Tayside in the longer term.
Thank you.
Okay, thank you for your questions and answers. We have next up we have Councillor Purvis and then Bob Benson. Callum.
Thank you, Chair. Can I ask on about the new monies that you referenced in relation to trying to tackle the drugs death crisis? Is that linked to, I know there's been announcements nationally about rehabilitation beds, and does that money fit into that? And also, I mentioned before about the desire to see more work done on prevention and recovery, whereas I personally feel there's too much of a focus on management of addiction. Is there scope within that additional funding to look at those type of activities?
If I could come in very quickly, first of all, the funding announcement comes with a set of very clear priorities that, from my recollection, spans all of what you've outlined, Callum, but I'm just wondering if Kenny Ogilvie is with us, who is the Vice Chair of the Area Drug Partnership, and he may be able to expand on those priorities.
Yeah, I think, Kenny, you were on the call. Are you on just now?
I don't think he seems to be on the list of people who are in at the moment, Chair.
That's
I'd be
unfortunate.
very happy to circulate to members after the
helpful.
meeting the Scottish Government letter.
Okay, thank you.
Okay, thanks for that. Okay, Bob Benson.
Thanks very much indeed for the report. It actually gives us a fair idea about where we currently stand. I suppose one of the questions that comes up from me is that, given the nature of the pandemic and how our attention has had to focus so much around that area, how much of this underspend is reflected by other IJBs who must be in a very similar position to ourselves? And I wondered if either Gordon or Jane could perhaps give us some sense of that, because I found it very difficult to believe that many of our issues are probably shared by others, that I think maybe makes us look again at perhaps around Ronnie's area about performance, because I'm wondering perhaps that there are other significant factors that are affecting this, and I wondered if there's any answer to that.
Jane, are you able to respond?
In terms of the level of underspending, I think what's clear across Scotland, Bob, is everybody's response to the pandemic has been different. The decisions that have been made around incurring additional spend has been different. Performance against delayed discharge, for example, has also been different. And here in Perth and Kinross, strategic performance has been very good, and that's what that means is we've moved people through the hospital, and we've created and kept the capacity, and we've been able to reduce kind of a number of areas where we may have seen costs. So I think the response across Scotland will be very, very different, and what that means, and in terms of COVID response itself, it's absolutely been different. And I think one of the reasons that we find ourselves with so much extra money is because proportionately our costs have been low, and therefore the amount we've got to carry forward is proportionately high. So it's difficult to compare. But certainly, some of the areas where we are seeing underspends around day services, for example, around respite, around carer support, they're undoubtedly going to be areas where across Scotland they've seen very similar, issues, because we've done these things under largely guidance by the Scottish Government about the stepping down of services. In terms of provider sustainability payments, again, which is a very significant part of our COVID payments, again, slightly, clear guidance from the Scottish Government, but nuances there too in terms of how different parts of the system have responded to that. And here in Perth and Kinross, I could say we've been very supportive of our providers and very quick in making payments. So, again, there will be differences across Scotland.
Thank you. I mean, actually, that's quite encouraging in many ways for what you're saying, Jane, is that actually there's a very positive story coming out of this as well. And I think I wouldn't want us to get over obsessed with the figures in some ways, but there is a clear case for us to take back to our funders ultimately, is that question about we are having wise spend here and we're spending as fast as we can do it. And clearly there are issues around about staffing in certain areas. I suppose my original question to Gordon was about how much time was being spent doing other activities that were much broader. And it's those kind of things that do we have enough management, etc., to help to spend those monies more? And I kind of asked that very basic question. There's no criticism of what's been done, of course, but it's just there is a reality about some of this, that looking behind these figures, there's a much more positive story to tell. That's all I wanted to get into. Thank you.
Okay, thank you for that, Bob, and thank you for your question and your comment, which I'll take as the first comment. If there are any further comments that members wish to make at this point in time, please put a C in the chat. Not seeing anything come through. Okay. Thank you, Jane, for your report. And if I can ask you now to, oh, sorry, there's a comment, Maureen.
Sorry, I've been trying to come in for a while, and I had said I would like to comment and ask some questions on item 9. And I put it up while we're talking about Gordon's report, and it was item 9 on there about mental health I wanted to speak about. You know,
sorry, item 9 in there. I thought you meant item 9 on the agenda.
The agenda. I thought that was maybe what you were thinking, but it was item 9 on the, you know, which is about the mental health. So okay. There's a few things I would like to comment on there. And 9.1 and again in 9.7, they said that they're using Action 15 money and remobilisation money from the COVID to enhance some of the services. Now, if that is, you know, to me that's temporary money. So is this just something that can't be sustained in the longer term? I would just like to know that. Then on 9.7, you say that there's been a 50% increase in staff. I know you can't do it right now, but could I have an account of where this 50% extra staff has gone? If it's in the community, that's a broad sweep, but it's the community mental health teams in particular that I was interested in, you know, seeing enhancements there. And I'd just like to know where this extra 50% staffing has gone, if someone could get back to me with those details. Then on 9.11, the Hearing Voices Network, could I just ask that that be corrected, please, because the Hearing Voices Network is a national organisation. What that should be there is Support in Mind Scotland are providing a service. It's a new service and it's Hearing Voices Outreach. It's not the Hearing Voices Network, which is a national organisation, and that isn't coming to Perth. So, you know, if we could have that corrected, please. Then the other thing was if I could have a note, please, because I've been asked to, you know, to ask this question of staff numbers, current staff numbers in community mental health teams, because according to graphs or stats data that we've collected, it shows that Tayside has the biggest number of inpatient service mental health staff and the least number of staff in the community. So, you know, but this is something that needs to be addressed. That's what data is showing, like, you know. So okay. It's got to be addressed. That so.
Okay, I think a mix of questions and comments.
Yes,
there.
I know some you can't answer right away.
No, and as you say, it might be difficult to answer these specifically at this time, but Jane, if you have any response to that at this time.
Yeah, certainly. In terms of your question about the sustainability of funding, Maureen, you're absolutely right. There is a mixture there. Action 15 funding is recurring, so the posts that we're recruiting to enhance community services through Action 15 are full-time, are substantive recurring posts that for which there is no risk to funding. Posts that we're putting in as part of our mobilisation plan are funded non-recurringly. We are looking for many of these posts to extend that provision as part of our 21-22 remobilisation plan, and we know that mental health is a very strong Scottish Government priority. Therefore, we're hopeful that we will get the funding we need to support extension of many of those posts. What we will then require to do is, and as part of the community mental health strategy, is understand what we need to retain for the longer term, and that will be part of what comes forward as part of the community mental health strategy when that comes forward to the board. I would like to suggest that that also answers your question about the numbers of staff that are in our community-based services, and that will be covered in the community mental health strategy. In terms of the 50% increase in staff, very happy to provide that out with the meeting. And in relation to the hearing voices, I'm very sorry if we've got that wrong. We'll seek to correct that.
Okay, thank you, Jane. Thank you for your responses, and thanks to Maureen for pointing out the unintentional error in the paper. So thank you for that. I don't see any further comments on this paper at the moment, so thank you for that. And if I can therefore now quickly move on to item 7.2 on the agenda, which is the 21-22 budget, and ask Jane to give a verbal update on that. Thank you.
Thank you, Chair. Colleagues will remember that at the meeting in December of the IGB agreed to development of a one-year 21-22 budget. That recognised the extraordinary circumstances of ongoing COVID response and levels of uncertainty. We shared with members the refresh of pressures, savings and income, including key assumptions around the outcome of the Scottish Government budget settlement. Scottish Government budget settlement was announced on the 28th of January with significant implications for health and social care partnerships across Scotland. Most notably, the uplift to health budgets, which was assumed to be 3% in line with this year, was confirmed at 1.5%. That's notwithstanding further funding to come out in specific regard to Agenda for Change and pay negotiations, but aside from that, this lower than anticipated uplift very significant implication for the Health and Social Care Partnership and leads directly to £1.2 million less funding than we were anticipating. Further, the £72.6 million funding announced for social care is not only significantly less than we've received for this financial year, but also includes significant ring-fence funding for additional Scottish Government commitments not included in our provisional budget, including a 7.5% increase to free personal care allowance and a further extension to living wage uplift beyond that which was expected. Overall, this has created a £1 million additional pressure in the social care budget. There has been additional funding above what we were expecting in relation to Carers Act, and that relates to error in previous calculations undertaken by the Scottish Government, and further work is underway to look at the historic costs in the system that this funding has been allocated to address. That's notwithstanding the continued significant further investment that remains in the financial plan in relation to further service development. So overall, the settlement as it stands at the moment, and notwithstanding the parliamentary process that will take place in March and which may change the outcome, but based on the current settlement, it will have a significant impact on our ability to deliver recurring financial balance in 21-22 and beyond. We're working hard to consider the non-recurring pressures and opportunities in order to bring forward a balanced budget, and we will look again at some of our intelligence around things like the National Care Home contract and in relation to things like prescribing growth and to look at whether those can be updated. Most importantly, we've continued to engage very collaboratively with Perth Kinross Council as part of their budget process, and in particular in recent days in relation to the impact of the Scottish budget for social care services. Thus far, there has been less opportunity for discussion with NHST side with regard to the budget, and we would hope that that would change in the few weeks ahead. I can provide reassurance to the IGB that all possible actions are being taken to bring forward a balanced budget, but it is going to be difficult, and that is despite the the significant COVID carry forward that I outlined in the previous report. We have a scheduled IGB BRG session on the 26th of February, an IGB development session on the 9th of March, and this will provide the opportunity to bring forward draft budget proposals ahead of formal consideration at the IGB on the 31st of March. Very happy to take any questions.
Thank you again, Jane, for your report. Are there any questions? Councillor Purvis.
Thank you, Chair, and thank you very much, Chief Financial Officer, for that report. Just a very brief question. It's probably a difficult one, so you may not have the answer yet. But in terms of this additional money that's ring-fenced for COVID-19 in the reserves as a result of the underspend, we would hope that, as we've had up to this point, that if we need any additional money, that we would receive that from the Scottish Government. Do we know that if that happens to be in excess of what we need, obviously we're hoping that we're moving towards a better position, whether we're able to retain any of that to spend on other priorities, or do we not know that yet?
That has been the very discussion that's taken place at the CFO network meetings across Scotland Council. It's a very, very pertinent question, and we don't know the answer to that. What we do know is that over and above any level of carry forward, there is some significant provision in the Scottish Governance budget for additional COVID expenditure next year. And we also know that Scottish Government are waiting the outcome of the UK budget to understand whether there will be further spending. We will as part of what we bring forward to the IGB, we will do our very best to understand what we think the likely costs of COVID are, but that work is ongoing, and what we bring forward in March will be a very broad estimate, and we will continue work on that. So when we bring forward the remobilisation plan to you in April, we will have a far better understanding perhaps of some of our increased COVID costs, notwithstanding that Scottish Government guidance around COVID response and priorities continues to change on almost a daily basis. So it's very hard for us to predict our costs, and of course our service colleagues have significant capacity issues in terms of trying to understand what some of our service enhancements need to be, and therefore what the funding needs to be to meet those. So it's not going to be easy to understand all of that, but there is additional funding earmarked to come, and we would like to make sure that we get our fair share of that if it's required over and above what we can carry forward.
Okay, okay, Callum, happy with that? Yeah.
Yes, sorry, thank you.
Right, okay, I'm not seeing any further questions, and I know Ronnie's comment insofar as it relates to this item on the agenda, and sorry you have to leave at this point, Ronnie. But thanks for that, and we'll come back to the remainder of your comment when we get to that item on the agenda. So if there are no further comments on this paper, or are there any comments? No. Okay, thank you very much, Jane, for your updates this afternoon, and we can now move on to item 7.3, which is a verbal update by Councillor Purvis, the Chair of the Audit and Performance Committee, and I'm sure that will incorporate reference to two of the papers that are in our pack for information. today, as these formed a significant part of that meeting agenda. Callum, over to yourself.
Thank you, Chair. Yes, the two main items I wanted to speak about are those two that are on the agenda today for information. The first was the strategic risk management update. We had a very lengthy, but I think important and constructive discussion on that paper. It brings together the previous risks that we had identified on our risk register alongside the new COVID-19 risks that we've been dealing with for some time into one combined risk register, which is something we were keen to see progressed. I think that the feedback from members was that it was a very good format, and it was easy for us to see the difference between the inherent risks and the residual risks and what action was being taken to tackle some of those. I think there are still a number of areas that we need to have discussion on, and we look forward to seeing the improvement plan, which will give more detail on how we try to bring down the residual risk scores further. There was also discussion about what is within our sphere of influence and sphere of control, because while there might be some things that we need to do in order to bring down those risk scores further, they might not be things that are directly within our remit. And we have to make the points to our partner organisations and other bodies that we deal with in order to bring that score down. So we undertook to have a further discussion about how we might best tackle that issue, and whether that's through resolutions at the board, or the lobbying from the chief officer, or indeed the chair of the IGB, and that's something that we need to continue to work on. There was also a desire to have a workshop looking into risk management in more detail, and also considering what the risk appetite of the IGB would be, because some of the actions and the improvements that we might want to do in order to meet our strategic planning objectives do have inherent risks within them, and so we need to consider what our appetite for that is, and we thought the best way to do that was through a workshop. There was also a request from Mr. Erskine about having workshops on specific issues, or taking a specific risk topic to the Audit and Performance Committee maybe once or twice a year, and I was more than happy to look to see how we can accommodate that in future. So on the whole, I think a very positive report, and we thank officers for all their work in bringing that together. As we stated before, the intention is to bring the risk register for more thorough discussion to the Integration Joint Board at least once a year going forward. So that was the first thing. There was also, we had the audit strategy from KPMG. They set out a number of the things that they're going to be looking at throughout the year, including financial sustainability, financial management, governance and transparency, also looking at things like register of interests and conflicts of interest, and also value for money. In addition to the standard fraud risks that they look at, they're also going to be introducing some new checks and analysis on COVID-19 grants. That's clearly something that a lot of organisations like ourselves are having to deal with, a lot of extra money, and we've dealt with that very well, but there is an inherent risk in processing that, so they're going to have a look to make sure that we've been doing that appropriately and report back. They are also going to report back on the 4 recommendations that they gave to us last year, and those were about our reserve strategy, the strategic planning and management capacity of the IGB, the risk sharing agreement and lack of clarity on that, and also the lack of regularity on board membership. And I think probably most of them, if not all, have come up as they often do in the agenda today. And that links back to our previous discussion about, sphere of influence and sphere of control. We absolutely support, as I made the point to KPMG, all of those recommendations, and we are trying to do what we can to progress them. But unfortunately, that does rely on support from our partner organisations in order to do so. Other than agreeing the audit fee, which we did, there's very little scope for changing that. The other substantive item, which again is on the agenda today, was the quarterly performance report. Again, there was an awful lot of good progress that we could see in there, an awful lot of green on that document. We did have a discussion on one key issue, which was about the readmissions figure, which was had declined. Had got worse, maybe decline is the wrong word to use, and that the question was whether that performance and decline in that number was due to the way in which it's reported across Tayside. Tayside reports its readmissions differently to most other parts of Scotland, and while it has been doing that for some time, so can't explain the difference in performance between months, it might explain why we're performing slightly worse than Scotland on that particular issue. Sorry, that is slightly complicated and I maybe haven't articulated it very clearly, but we are asking for more information on that so that we can be assured that we are doing what we can to address that issue going forward. But other than that, the performance on the key indicators that we look at each time we get a quarterly report, and which will feed into the annual performance report each year, were broadly good and showing good progress. So I know the Chief Officer mentioned that we often, we as board members are perhaps guilty of scrutinising where we aren't performing, but it is important to highlight the areas where we are performing well, both locally and in comparison to Scotland. So I think it's important to highlight that too. But I'm happy to take any questions on any of that.
Thank you, Councillor Purvis. Thank you for that report. Are there any questions for Councillor Purvis? I have one myself, but are there any others before I chip in? Appear to be. Callum, my question, and as you know, I was present for part of the meeting and did view the remainder of it. 12:30 in the morning, but never mind. Something which, when I previously attended the Audit and Performance Committee, I was concerned to try to find out more about, and something that I've been asked about as an elected member myself, no doubt you have as well, is when we're talking about emergency admissions into PRI in particular, or any of the hospitals, obviously, there's a perception, rightly or wrongly, that the number of falls can be a concern, and you know, I'm kind of linking that in my mind's eye to the way the local authority, whether the the winter interventions that we have are adequate. I'm not making any observations other than just it's a question in my mind's eye. Is that something that that we can drill down to and establish? You know, if outside falls in particular in the winter months are a prominent factor in the emergency admissions figures.
Okay, thank you. I'll perhaps ask if officers want to assist in the answer, but I'm certainly happy for the committee to look in that in more detail. I do know when we had a previous discussion, this is I think well over a year ago now, about winter planning, that was something that was raised, and I know that there was recent press coverage about some of the admissions in PRI over the period when there had been significant snowfall. So certainly that's something, and if that is the reason, and I'll hand over to officers in a moment, then I'm more than happy to write to the council and all the political groups to make that point, to see if that's something that they could look to consider in the budget process.
Thanks. Evelyn, you've got your camera on.
Yeah, I mean, I know we've done a bit of a deep dive into this before, Chair, but and we certainly have access to that where we've seen peaks in winter time. We always do, of course. So it's whether it's attributed to outdoor ice and snow, etc. You know, I think that would be more difficult to prove. But David McLaren, one of our researchers, has been looking into that. So there may be more information available, but I'm just not quite cited on it. So I'm happy to take that away and see what information we could share with you.
That's helpful. Okay, thank you. Are there any other questions or comments for Callum? No. Okay, thanks, Callum, for your report, and I did find the meeting very interesting, so that was good. Item 7.4 is now the forward planner. And again, Gordon, do you want to come in at this point?
Yes, thanks, Chair. Really just to point out to members that the current arrangements for bringing forward reports are as described in the forward planner, which is self-explanatory. It does, however, now reflect the fact that we have deferred some items, and we will need to keep a weather eye on the extent to which, having done so, subsequent IJB agendas are manageable, and whether or not there may well be other reports that need to be deferred, or potentially other ways of ensuring IJBs are apprised of those reports that are sometimes only for information rather than for decision, which could perhaps be circulated offline or summarised in our fortnightly bulletins. But that's the intended planner for the next number of meetings, and we will continue to review the various reports that we're proposing to bring forward. And we'll also, in light of the discussion that we've had today, need to think about a development session around the Feely report.
Yeah.
And in light of the discussion we had on Monday that Councillor Purvis has just referenced, to give consideration to how we can arrange and when we can arrange a session around strategic risk and risk appetite, etc.
Thank you for that. Yeah, and yeah, as you say, it's been very clear, very clear this afternoon that there's a desire for a session on the Feely report, and we'll need to try and find a way to factor that in, and perhaps we can have that discussion in early course and see what solutions we can arrive at. Are there any members who have any further questions or comments on this paper? Nope. Okay. That's fine. So the item 10 is, as I say, you have future meetings and development session dates for your diaries, and hopefully we can ensure that the key business items on our minds and on our agendas are covered as promptly as possible. So there does not appear to be anything further on the agenda this afternoon. So without further ado, I'd just like to thank everyone for your attendance today and your active participation in the meeting. I think it's been a constructive discussion and some very full answers to the questions and challenges that have been posed. So thank you to everyone for your attendance this afternoon, and the meeting is now closed.